Hi, I'm Mukul, one of the A&E registrars currently working in ICU. So this project is on RSI in resus, Rapid Sequence Induction, and it's an area our trust has been working on for a long time. Many years back, the RSI drug box was introduced, then one of the other registrars, Byra, introduced the difficult airway trolley. This project I'm doing is just the latest in a long line of projects, and a big part of it is education and training, which is why I've taken the time out to try to make this video. The NAP4 study, National Audit Project with the Royal College of Anaesthetists, did find that resus patients 36 times more likely to need airway interventions and ICU 56 times more likely. So both of these are really high risk areas. And they found a number of things: failure to plan for failure, failure to assess for a difficult airway. Sonography was seen as one of the single most high risk areas and ways to prevent mortality. And this is both to do with the sickness of the patients and the unfamiliar environments compared to theatres that are set up for this. So the more we can do to improve the safety for this, the better. So what can we do, and what have we done? So NAP4 recommendations included the difficult airway trolley, which has already been done. Another recommendation was to have a standardized process and RSI checklist, and that's been introduced recently by Dr. Flavin in ICU, and part of this project was for seamlessness to introduce that down in resus. She's given permission. We've already started that. So we've started that, and the other side is education and training. And this video is around that checklist on training on that. And then there'll be some more videos that other people have really kindly agreed to do. So a big thank you to Harriet, one of the resus A&E nurses, who distributed the questionnaire among all the other nurses, and it did show that people would like this, would help with the training, and it will open things up, remove the mystique, make it from a task-oriented to goal-oriented approach, because the more people that are involved, the safer it can become. If everyone's looking out, oh, you forgot this, you forgot that, lots of people, lots of minds on that same track will help with the safety, as we've seen with sepsis, with the sepsis 6. So that's the aim. So I hope you like it, and this is that first video, so let's get straight into it. And any questions, anything, just let me know. Okay, take care. So in resus, we have the different pull-out drawers, and one of them has been labeled RSI checklist. If you open that, you'll find this checklist, which is the same one that's used in ICU. And we've got red, yellow, and green. And the red and the yellow is actually all mostly preparation, which is one of the most important parts of this. And then the green is the sign out, which we'll go through this in a bit more detail. The back of it is something to be filled out by the intubator, and this can go a copy into the notes that go up to the ICU, with the original to go in the folder in resus. This is in most cases to be used, but there will be certain crash intubation situations where it would take unnecessary time to do this. Now, 7 Ps, of which preparation is the most important and will take the most time. This preparation includes loads of things. It's about the environment, about the equipment, and these are some things that we've looked at from the Scottish Intensive Care Society guidelines on RSI for assistance, and it's really useful. So checking the resus room, the monitoring, IV access, 2 lines, positioning, is it a tilting trolley, are all the drugs labelled, checked, do we have the right equipment, right size tubes, is the laryngoscope blade working, do you have a bougie suction? And you'll see this in the red bit of the checklist. All of this goes in detail, and we will have a video by one of our ODPs which will show this with the actual equipment later on. Now, another big part about preparation is verbalizing and going through plan A to D, and this is something that's shown in this guideline here, the Difficult Airway Society Guidelines 2015, and essentially this is so every member of the team knows what to do in the event that intubation is unsuccessful, because patients don't die from unsuccessful intubation, but they die from unsuccessful ventilation. So there needs to be a clear plan as to what to do if intubation fails, and for every person to be aware of that. And this is plan A, B, C, D, according to the difficult airway guidelines, where you move on to, after laryngoscopy, trying something like an eye gel supraclavicular device, face mask ventilation with the Goodell, and a plan D as an emergency is an emergency front of neck access. And you look on our checklist, if you look at the yellow section of our checklist, it will go through this in detail. And this is something to just remind everyone to consider and think about, that we have all of this stuff before starting the rapid sequence. Now, preoxygenation is the next P out of the 7 Ps. And these are Ps of rapid sequence induction. And again, this slide, half of this slide, is courtesy of the Scottish Intensive Care Society guidelines, and we can see how long it takes for someone to desaturate from 100 to 90% oxygen in different situations. And you can see that the time of 8 minutes in a healthy 70-kilo adult goes down rapidly as you go to an ill patient, a child, an obese patient, and a very ill patient. And this is with absolute preoxygenation and in a best case scenario. But once saturations reach 90%, they drop a lot quicker to 0%. So once they go to 90%, we don't have very long, and we shouldn't be continuing to try to intubate, but we should be focusing on ventilation. While we think about very ill patients with altered physiology in resus and ICU, we do need to bear the lower end of these numbers in mind. And we've seen this in the NAP4 guidelines, that these are the patients who are much more likely to require airway interventions. Pre-treatment paralysis with induction are the third and the fourth Ps, which are a little bit more concerned with the anaesthetist or the person doing the intubation. So I won't go too much into detail with this. This is also to do with the drugs, with optimizing the patient beforehand as needed, and we can spend a bit more time in face-to-face teaching on this. Protection and positioning. So protection is about cricoid pressure, and I know there are different views on this, but for now, per the different guidelines we're using, we apply cricoid pressure as a form of protecting the patient against aspiration. This diagram shows what to apply, and as it says, it's just that amount of pressure that's a little bit uncomfortable when pressing on the bridge of the nose. What's really important to bear in mind is that in a case of a difficult intubation where the intubator is not having success, they may, as one of their things to optimize the view, say to you to slightly relax the cricoid pressure. So leave that to their discretion. And this diagram shows about cricoid pressure on the left. On the right is positioning. So we have lots of different patients in resus, many patients with C-spine trauma. Again, you'll see on that red, yellow, green section that there's a specific section in the preparation red and yellow aspect about considering a patient with a C-spine injury where the cervical column may need to be replaced by manual inline stabilization by an assistant, and this is maintained to protect the C-spine during the intubation. When trauma is not suspected, other things can be done in positioning to improve the view, like putting a pillow under the neck to help align the axis, and if you get a good view of laryngoscopy, it improves the chances of success of intubation. Placement with proof. Now, end-tidal CO2 is likely one of the key things from an assisting point of view, and it was consistently identified in the NAP4 National Audit Study as one of the single most important areas for the assistant to be aware of and anticipate for patient safety. Drive home that to really know the end tidal well, have it prepared, we all know where it is, and we're ready to connect that with the intubation. The other areas of placement with proof are auscultation and direct visualization. Post-intubation management. So after the intubation are done, the procedure isn't finished, and you'll see on the green section of this guideline we have a lot of things that are listed in detail there, but there's a lot of things to do afterwards, including ongoing capnography, ECG, SATs, BP monitoring. An outline may be required, so setting all of that up. Key things, setting up and administering infusions for ongoing sedation and muscle relaxation, so the patient doesn't have awareness. So we know that emergency situations are high risk for patient awareness, and particularly in areas like resus and ICU. So having the appropriate sedation infusions, and ideally if there's time before the intubation rapid sequence, we can have this prepared even before. And what's a key thing to have this as a multidisciplinary thing, and especially enhanced nurse teaching, is like we said, and like with the sepsis 6, if 10 people are thinking on the same thing, lot less chances of errors happening, and that's part of a big aim of this quality improvement project. Setting up an ongoing mechanical ventilation, ventilators like Oxylog 3000, so an operator can be freed from the bag valve, and hopefully, ideally, if people are interested, maybe we can even have a few sessions on the Oxylogs and the ventilators in resus. Here is the checklist again, just to remind, as we've been through the 7 Ps, you can see on the red section, on the sign-in section, about introducing, positioning, spinal precautions, pre-oxygenation, which we went through, cricoid, preparing all the different equipments, having all that ready. And we've got the yellow section, which is a large part about being aware of the 2015 Difficult Airway Society guidelines, at least going through that do we all know our roles? Do we all know the plan A to D? What is our plan A to D in this situation? Is our positioning okay? And the green section is what we mentioned about the post-intubation management, about the positioning, placement with proof, tube ties, ventilators, sedation, etc. So this is a whole guideline that we have. It means we've got a good standardized process and we know it's happening safely. It'll increase awareness and mean the whole team is involved. Preparing copies of these lanyards, these nice cards given to me kindly by one of the consultant anaesthetists, and we'll try to distribute some of these later amongst resus nurses. Thank you, and I hope this teaching was helpful.